My name is Dr. Selwyn Rogers. I'm the Vice President and Chief Medical Officer of the Health System here at UTMB. I want to thank each and every one of you for taking the time out of your very busy schedules to attend this important event on occupational bloodborne exposures. This has been an issue that plagues many institutions, including our own, and affects a broad range of our employees, from residents to physicians, nursing, and even housekeeping. This lecture is designed to increase awareness and change culture, and thus we have invited Dr. Henderson, a world expert on the topic of occupational bloodborne exposures. We hope that by the conclusion of this presentation, you will learn the following: the magnitude of risk for infections with various bloodborne pathogens following occupational exposure, strategies and interventions that are associated with reducing these occupational exposures. Look at critically the evidence for the use of immuno and chemoprophylaxis for exposures consistent with current UPHS guidelines. And then finally, the presentation will serve as a foundation for ongoing cultural change here at UTMB on making this the safest place in the world to work. That's certainly what we want for you and for all of y'all. I'm working on my Texas slang, the whole all of y'all thing. I have a few logistical considerations and housekeeping items before we begin. For those seeking CME and CNU or CNE, continuing nursing education, for your professional development activity, please make sure you have signed in at the entrance or signed in at the exit. It's important to note that there are no conflicts of interest or commercial support sponsorship identified in this presentation. That includes discussion of unapproved, off-label, and/or investigational uses, prophylaxis of one or more products, including antiretrovirals, and interferon alpha. As a disclosure, that Dr. Henderson will also include his spouse works for Merck. However, she is in no way affiliated with the information presented today. The University of Texas Medical Branch Continuing Nursing Education is an approved provider of continuing nursing education by the Texas Nurses Association and an accredited approver by the American Nurses Credentialing Centers Commission on Accreditation. Before I formally introduce Dr. David Henderson, I want to personally thank a number of people who contributed significantly to this event. Of course, I want to thank and acknowledge our leadership of Donna Sullenberger, Dr. David Jacobs, and Dr. David Callender, who continues to demonstrate our commitment to safety by shining a light on this issue of occupational exposures to bloodborne pathogens here at UTMB. In addition, as it takes a village to raise a child, it takes a large group of people committed to pull off an event like this over the next day and a half. That includes our organizing committee, Ms. Stacey Usey at the outset, Christy Benton, who's done a yeoman's job of continuing to take the baton and run with it, Candy Gallen, Michael Rape, and Dr. Alpha Cass. Without their efforts and meticulous attention to detail, this event would not be possible, so I thank them all. Dr. David Henderson, our honored guest, serves as the Deputy Director for Clinical Care and the Associate Director for Clinical Quality, Patient Safety, and Hospital Epidemiology at the National Institutes of Health Clinical Center. He's the primary author of the Society for Healthcare Epidemiology of America Guidelines, whose mission is to prevent and control healthcare-associated infections and advance the field of healthcare epidemiology. He has authored over 130 peer-reviewed articles on infectious diseases and epidemiology. He has been honored with numerous awards throughout his distinguished career, including 2 Department of Health and Human Services Secretary's Distinguished Service Awards and 6 NIH Directors Awards. I actually had the fortune of meeting Dr. David Henderson in the context of serving on the CDC's Healthcare Infection Control and Prevention Advisory Committee. And I was always struck that Dr. Henderson was kind of like E.F. Hutton. He didn't say very much, but whenever he spoke, everyone stopped and listened. The measure of a man is often, or woman, is often determined, I think, by what they may have written or what they may have done during their lives. Another way to measure a man or a woman is to ask them what are the 3 biggest influences on their life. And Dr. Kirschbaum and I had the benefit of having a fine dinner last night, as dinner. And this was Dr. Henderson's, he didn't realize I was actually prepping for this, but this was his response that I garnered from his comments. First was his marriage to his wife of over 37 years. The second was the training at UCLA. And it wasn't really about UCLA, it was actually about the proximity, given the fact that Dr. Henderson is actually from Indiana originally and is a farmer's son, the proximity to Napa Valley. And that's where he fell in love with wine, especially Cabernets. And then the third important influence in his life was the death of a colleague at the NIH Clinical Center. Dr. Henderson will present his work on prevention and treatment of occupational exposures to bloodborne pathogens. As a pioneer in this area over the past 3 decades, it's my distinct pleasure to introduce Dr. Henderson.
Thank you once more. Yep. So it's indeed a pleasure to be here. I'm going to spend the next 50 minutes or so talking to you about a subject that I've had a long-standing interest in, hiking back all the way to the early days of the HIV epidemic as it unfolded in the United States. I was sort of at ground zero in some respects because at the clinical center, we started having these patients admitted to the hospital before anyone knew anything about it. And so it was sort of a frightening time. That's how old I am, so that helps you. Regarding Selwyn's comments about my spouse, she would like to think that she has some influence over what I say, but I can assure you that she doesn't. And she would tell you that as well. So when those first patients were admitted to the clinical center, I called up my friends in Atlanta and said, listen, what do you know about this disease? What's the epidemiology like? Are healthcare workers at risk? And in their own inimitable way, my colleagues said, well, we really don't know, but we don't think that there's a healthcare risk. Try telling that to the nurse at the bedside. They're not going to buy that. So our response to that was to start to study the issue, and that's sort of how I got on board. What I'd like to do in the next 50 minutes or so is to talk to you a little bit about how we came to know about this disease in a crude sense, the epistemology of HIV infection in the United States. I'd like to talk to you about the magnitude of occupational risks for hepatitis B, hepatitis C, and HIV in the healthcare workplace. We'll spend a fair amount of time talking about primary and secondary prevention, and then I'll talk briefly about the rationale and guidelines for managing occupational exposures to each of these pathogens when they occur in the healthcare setting. And if there's time at the very end, I'm going to spend just a few minutes talking about a subject that's painful for most healthcare workers, and that's transmission in the other direction. So if you have a provider who's infected with one of these pathogens, how do you manage that, and what's the risk for transmission to her or his patients? So this is the first information published in the United States about the disease we now know as the Acquired Immunodeficiency Syndrome, or AIDS. That was published in the June 6, 1981 Morbidity Mortality Weekly Report, and it wasn't even important enough to be on the front page. Talked about 5 patients in Los Angeles, and no one took it too seriously, but as most of you in this room know, it soon became a national and worldwide epidemic that still is going on. For those of you interested in history, this was the original CDC iceberg slide. Talked about the fact that a lot of the disease had to be submerged that we weren't seeing, and what we could see was just a very small part of what was going on with this disease. Unfortunately, most of us, and when I say most of us, I mean not only the lay public, but also healthcare workers, learned about this disease from the lay press. And I guess if I've learned anything during my association with this disease for the past 35 years, it's that the lay press is not necessarily in the business of providing you with perspective about this disease or any other topic. What they're in the business of is improving their ratings, selling more newspapers, and doing anything they can to make their lives more profitable. And that was certainly true about HIV. Virtually every major news magazine had 1 or 2, some 3 or 4 covers describing the epidemic. This one from Time, this mysterious deadly disease called AIDS. This one, or that's Newsweek, this one from Time, tracking the killer of the AIDS hysteria, and on and on and on. No cover, however, more than this one, caused me more heartburn. At the time this cover went on sale in the R&W shop in the basement of the clinical center at the National Institutes of Health, we'd already provided care for about 500 patients with this syndrome. And I can assure you that the concept that now no one is safe from AIDS in big, bold red letters didn't do a lot for the confidence of the healthcare workers I'd been talking to for the past 4 years. From this particular issue of Life magazine, I learned 2 things. The first is that the healthcare workers who work in my hospital don't read the article on the inside of the magazine, they just read the cover. Because had you taken the time to read the inside article, it really gave you a pretty clear perspective on how you could get this disease and what things put you at risk to get it, and one of them wasn't healthcare. The other thing I learned is that safe is a relative term. You're never safe, don't feel safe. When Christy picked me up this morning, she told me that she was still asleep and she was driving the car, and so trust me, I didn't feel particularly safe at that point in time. For this disease, our society wanted absolutely zero risk, and there is no such thing. And that was a tough pill for people to swallow, and so we still find ourselves periodically, as the great Yogi Berra would say, sometimes deja vu all over again. With Ebola virus infection, I found myself answering many of the same exact questions about what the risks were in the hospital, same people even, at the same microphone in the same building. Again, for those of you who have historical interests, this is a picture of Ryan White, after whom the legislation is named, the HIV legislation. That I think has been a huge boon. I had the distinct pleasure of being on the podium a couple of times with both Ryan and his mother at various conferences over the years. Now, some of our major medical journals have contributed to our understanding of this disease. Here's one in which this lovely woman murdered her husband with an AIDS cocktail. Note that he probably should have had a V8. This one, which is my long-standing favorite from the Weekly World News, now defunct, but I was so enamored with it in the middle of this epidemic that I actually subscribed. I hate to admit it, but just to make slides, because there was always something good in it. Every time you had a chance, you could have something new to say. But this is my favorite one of all time. It has no fewer than 4 stories describing the HIV epidemic. Nursing mom gives baby AIDS, worldwide plot by homosexual terrorist groups to spread the virus, terrified women infected with HIV after artificial insemination, and on and on and on. But what's unique about this one, and the reason that it remains my favorite, is that in their own inimitable way, the staff of the Weekly World News have chosen to provide you with perspective. It's there if you look for it. Refer, if you will, to the upper right-hand corner, where it says, "Ghost shocker, dog dead for a year pulls drowning twins from lake." And I think you do gain some perspective. If you're going to believe all these stories, you have to believe the dead dog story. And I submit to you that it's not terribly likely that the dead dog actually dragged the twins out of the lake. There is some good news. The number of vampire attacks has actually dropped dramatically in the United States. So early on in the epidemic, there were people who were really terrified, and people in the healthcare profession who sort of fanned the flames of that hysteria. And in particular, one surgeon from the West Coast who went on 60 Minutes, the national news, and told everybody that the federal government was lying about this, that there was a huge epidemic of HIV infection among the healthcare workers of the country. They were going to spread it to all of their patients, and before you knew it, the population of the United States was going to be decimated. That was 30 years ago. And so we now have tincture of time to analyze her assessment of that. I actually have a fond spot in my heart for that woman because she actually traveled me all over the world. Wherever she would go and start a fire, I got to go and try to put it out. So it was really fun. I went to Australia, I went all over following her around. So here are the data now, 30-some years in. There are in the United States 58 people who have sort of gold standard occupational infections with HIV. By gold standard, I mean these are healthcare workers who had an occupational exposure to something that was contaminated with blood from someone we knew was infected. They had a baseline sample drawn to show that they themselves weren't infected at the time of the exposure, and then following over time and in temporal association with their occupational exposure, developed signs and symptoms of HIV infection. The later ones of these have even had sequencing data to show that they're the same isolates. So 58 cases in the United States, 49 cases the rest of the world. There are obviously many more than that, but it's not a silent epidemic is what it's not. 52 of the cases were associated with needle stick or parenteral exposures, sharp object exposures. 7 were associated with mucous membrane exposures. The clever mathematicians in our audience have already noted that 52 and 7 don't make 58, but one of these people had both a mucous membrane exposure and a parenteral exposure, and we don't know which one caused infection. So what's the single hit risk? If you stick yourself with a needle contaminated with blood from someone that you know is HIV infected, what's the chance that you're going to acquire occupational HIV infection? We know these data from the longitudinal studies that have been published that have analyzed this risk. So there are 21 such studies. These are studies of healthcare workers who had documented parenteral exposures with a blood-contaminated device from someone that we knew was HIV infected into a healthcare worker that we knew was uninfected. And then the workers followed over time because all of these studies were carried out in the pre-antiretroviral era. So there was nothing to do. There was no intervention. So this is sort of an elegant natural history study in these 21 sites, one of which is from the clinical center and from my staff. In these studies, 6,267 participants sustained 6,498 parenteral exposures, 21 infections for an overall infection rate of 0.34% and an infection rate per exposure of 0.32%, roughly 1 infection for every 325 documented occupational exposures to blood, parenteral exposures to blood from someone who's HIV infected. I was stunned by these data. I anticipated that number would be much higher. It's a bloodborne infectious disease. And the reason that it's not higher remains one of my favorite questions in medicine, though I think I'll share with you what I think is some aspects of insight into the answer to that question. So when I look at these data, I'm always reminded of the old Henny Youngman joke when they used to ask Henny Youngman, "How's your wife?" He would always look at the person and say, "Compared to what?" So how does that 1 in 325 risk compare to risks that are highly prevalent and present in the healthcare workplace that we work in every day? Well, here's a risk that most of you know. I'm sure everyone in this audience has been vaccinated with hepatitis B vaccine, and everybody here is a responder, and so this is not applicable to you. But if you are someone who is susceptible and you stick yourself with a needle from someone who has a high viral burden, the chance that you'll become infected with hepatitis B without an intervention is 27 to 43%. And if you do get sick, the chance is between 6 and 24% that you'll be sick enough to be in the hospital with it. So it's not a trivial infectious disease. Hepatitis C is intermediate. 25 longitudinal studies with about 2,500 exposures, 44 infections, for an infection rate per exposure of roughly 2%. So if you think of them in decades, 0.3% for HIV, 3% for hepatitis C, and 30% for e-antigen positive hepatitis B. It's a reasonable way to remember it. The data are a little bit not quite right, but it's close enough for government work, as they say, where I come from. These data probably shouldn't be combined because they use several different detection systems. I did it when I published a review of this subject, but the real number, I think, is likely in the 2% range, and the 22% is using PCR, and no one knows what one positive PCR means. So how do you keep from getting infected? From my very favorite medical journal, the Washington Post, an article back from 1984 about the Bhagwan Sri Rajneesh, who then lived on his own reservation in Portland, outside of Portland, Oregon, with all of his followers, and who became my hero because he had 52 Rolls Royces, all painted in jazzy colors. Here you can see many of his cars. He drove each car for only 1 week of the year and then put it away and then drove the next one for the next week, and that was part of his style. But he was my hero because he told us back in 1984 that first we should stop kissing each other, but more importantly, 4 lines down, that he already wears gloves during sexual intercourse. What? The guru has the right idea, but he has the gloves on in the wrong place. So, how do you keep from getting infected? Standard precautions. Started out as universal precautions in 1987, I think among the most sensible guidelines ever issued by the CDC. Put healthcare workers in the driver's seat, said whatever you're going to do, you think about it. If there's a chance you're going to get blood on your hands, you should be wearing gloves. If there's a chance for spattering or splattering, you should be protecting your mucous membranes. That morphed into standard precautions, which talks about the potential for transmission in either direction, from patients to staff and staff to patients. But I think if we could routinely have this become an integral part of our healthcare behavior and really behave according to those tenets, the environment in your hospital would be much, much safer. So here's the only math equation I'm going to show you during my talk. It's a pretty simple one, and it's one that's a major take-home message for everyone in the audience. As healthcare professionals, we become pretty cavalier about blood exposure. It can't be anymore. There's too much risk associated with it. We don't even know what all the risks are yet, and there will be a hepatitis H, J, K, and other bloodborne infections, other retroviruses will be identified because there are a lot more of them than there are of us. But if we can use primary prevention strategies to mitigate the risk for and minimize blood exposures, then we can make the environment astoundingly more safer. So in 2015, the thoughtful use of universal or standard precautions, retraining staff about the occupational risks that are present in the healthcare workplace. This is not a particularly safe place, the healthcare workplace. It's not terribly risky. I mean, there are riskier places. You could be a fireman, a policeman, or a real estate agent. Those are all more risky than being a healthcare professional. But think of all the things that are in our environment, all of the toxic chemicals, all the chemotherapeutic agents, all the things that present risk to you on a daily basis that we generally just sort of ignore. To modify procedures and work practices that are intrinsically risky. And so if every time you do procedure X, you stick yourself, there's either something wrong with you or something wrong with procedure X. Admittedly, a 1 in 325 risk is not that astounding a risk to take, but if you take it every day of your life, you're going to ring the buzzer. This is a buzzer that you don't want to ring. It's a life changer. I think we need to modify our training curricula to make sure that all the risks that we understand in the healthcare environment are covered and emphasized as people are going into these trades. And I think that we need to use technology as we can. I mean, be skeptical. When someone brings you a new device and says, this is safer, it costs 3 times as much, but this is safer, don't just take their word for it. Look at the literature. Make certain that it is both cost-effective and effective. And finally, vaccination is a strategy that we'd all like to use the most. It works for hepatitis B, and hopefully someday we'll have one for these other 2 pathogens as well. So here's a slide which is associated with one of the 3 things that changed my life. This is a slide of parenteral exposures to blood occurring in the NIH Clinical Center from 1985 to 2014. Remember, I said that we started having HIV-infected patients in the clinical center in 1981, and by 1985, we had already had about 500 patients in the hospital working on the pathogenesis, the immunopathogenesis, and trying to figure out therapy. Most of you may not be aware that the drug AZT was born at the clinical center. Zidovudine was a product of the work that you paid for in part at the NIH Clinical Center. But in 1988, one of the technologists working in our transfusion medicine department did something that I've done hundreds of times, if not thousands of times. She had a clotted tube of blood. She spun it down in the centrifuge, took her 5th finger, took the red stopper out with the 5th finger, pipetted off the serum, and then took her 5th finger and cranked the stopper back into the tube to restopper the tube. And as she did that, the sidewall broke out of the tube. She cut her finger. 19 days later, she had the acute retroviral syndrome, and 2.5 years later, she died. And we watched her die. We did everything we could for her, but we had nothing to do. There were no drugs. We didn't have anything to do for her. We took the best care of her we could. Changed my life. This became really important to me. I said, how could we be doing this and not be doing absolutely everything we can do to minimize the risk for these exposures? I mean, once the infection, at that point in time, once the infection occurred, it was just a matter of time. We didn't have anything else. And so we put together a team, which included our safety officer, our occupational medicine doc, who's terrific, our ID team, surgeons. Everybody got together, and we met and processed through every documented blood exposure that we had. We looked for common circumstances of exposure, common devices, process issues that we thought increased the likelihood, and we really made this just an enormous organizational improvement project. And I think you can see that we made pretty substantial progress. So it can be done. You guys, I think, are in the same situation right now. You just haven't rung the buzzer. But you have lots of occupational exposures, and you all in this audience can make that go away. It'll take your work, not the work of the team, because people have to believe and listen and do what the team helps you understand. So the components of an aggressive program in a hospital include maintaining a culture of safety. It's very vogue now to talk about a culture of safety for our patients, but the culture of safety has to also encompass the staff. You have to feel safe here. One of my colleagues who works for me and really is the person who does patient safety for the clinical center goes weekly to different units in our hospital and asks the staff, what makes you feel unsafe? What makes you feel unsafe for your patients? And we process through all that information, trying to get to a higher level of culture of safety in the organization. The institution has to develop, publicize, and streamline and make certain everyone is aware how to gain easy access to injury reporting mechanisms. Someplace in the neighborhood of 20% of exposures probably get reported. It'd be a reasonable guess. 80% are ignored. You have to get people to report them. I know that when we first started doing this, we saw a huge spike in reports, and my boss thought we were losing the battle. I was encouraged. When in our patient safety program, we have an occurrence reporter where people put in things that worries them. The first one we got 300 reports a year. All my colleagues were only getting 30, all written out in hand. You probably remember those triplicate forms. And so I would go to conferences and say how wonderful getting 300 was. I thought that was terrific. And then I made the mistake of talking to our nursing staff who said it's a joke. It's a black hole. We put stuff in there when we're mad at people, and the only reason you get 300 is because it's easier to put them in because we didn't want to take the time to write out those triplicate forms in the past, but it doesn't do anything for us. So we sat down with them and said, what can we do to make it better? They helped us design an electronic reporter that involves feedback to the staff. So if you put in something, you get something back. You know who to call, and you can see what the resolution is. We now get 6,000 reports a year, and that's because people have confidence in it. You have to create metrics for all of these things and measure how you're doing. If it takes a surgeon 8 hours to go report his exposure and to get his treatment, he'll do it one time. If it takes 1 hour, he'll do it all the time. You have to engage the hospital safety officer, all the components of this team, and make certain that everyone is a part of this and contributes their own expertise. As we do, process through every exposure you get, treasure them, because you're going to get information from these exposures that you can't get any other way. Work on improved reporting, benchmark and compare best practices. All of these things are components of a program that will help you, I think, get to a safer environment. First aid principles are pretty straightforward. Rinse the wound. People often ask me, should I douse it in Clorox or betadine? No one knows whether that makes any difference or not. Once you've got it rinsed out and you're sure your patient is safe, report immediately to your supervisor and then immediately to your occupational medicine service. You have an occupational medicine service here that's engaged on this issue, that really cares about it, and I think likely will support you very well getting in and out of the system to get you to the point where you get the best care you can. The source obviously needs to be evaluated, and the occupational medicine service will also provide post-exposure care and counseling. The counseling is not trivial. It's an exhaustive process, especially for HIV. People worry about what they can and can't do, what they should or shouldn't do with their kids or their sexual partners or all of this. So you answer all those questions the first day. You can rest assured they'll come back and ask you exactly the same question the second day because they're just in shock when it occurs. It's a real medical emergency in many respects. So let's talk just briefly about hepatitis B. I'm not going to spend a lot of time talking about this. We still have lots of chronic hepatitis B carriers in our catchment. The patient population that comes to this hospital, you're going to find a lot of people who have been multiply transfused, patients with chronic renal disease, patients with malignancies who've been transfused, injecting drug users, and immigrants from high prevalence areas. So we still have an astounding level of risk out in your population. And annually, in the United States, we still have healthcare workers, probably 10 in that ballpark, dying every year of occupationally acquired hepatitis B, despite the fact that everybody in this room has been vaccinated. If you are a non-responder and are not infected, can't respond to the vaccine, and you have an occupational exposure to hepatitis B, you should go to the Occupational Medicine Service and they'll give you hepatitis B immune globulin. The dose is 600 to 700 milliliter per kilogram, and they'll give it to you at baseline. If you could be vaccinated, they'll vaccinate you, and if you can't be vaccinated for one reason or another, they'll give you a second dose in a month. There is no scientific basis for that, but since the recommendation for that initially came from one of my colleagues at the clinical center, we do it, and a lot of other people do it as well, but there's no clear science for it. There are now several marketed antivirals that have activity against hepatitis B. No one knows what their role will be in this setting yet. It's too early to call. Their efficacy in the treatment setting is not at the same level of efficacy that we're seeing with the new hepatitis C drugs. So it's not currently recommended. For hepatitis C exposures, at the clinical center, we test the patient for hepatitis C antibody and when appropriate by PCR to get some bearing on the viral burden. For the exposed healthcare worker, we get baseline serologies and PCR. We don't any longer do aminotransferases. Staff who then are followed by us every other week with a PCR. You don't have to do it that frequently. We're interested in sort of the natural history of this infection as it occurs. If the PCR is positive, we repeat it because one PCR doesn't make a summer. But if the person is repeatedly positive by PCR, then we set the clock. And we use a strategy that we call watchful waiting. And the reason we do that is because there is a fraction of folks will spontaneously resolve their own infections. And then there is the question mark there that post-exposure prophylaxis is likely on the immediate horizon. So why do you want to treat early? The data are really pretty clear. These data from Yekel and co-workers, an article published in the New England Journal where they looked at patients who had acute C. They treated all of them with a modified regimen with just interferon alpha for 6 months, which is about half of a course that we would give to someone who's infected. And 42 of the 43 evaluable patients were free of HCV RNA 24 weeks after therapy, so they basically cured them all. The 23rd patient, or the 43rd patient, actually was retreated and cured, so their cure rate was 100% just with this modified regimen. 14 of those were healthcare workers who had occupational exposure, and I won't go through the rest of the data about their treatment course. So patients with hepatitis C are an unusual population of patients. I've been doing infectious diseases for 35 years, and I've never seen anybody with acute hepatitis C infection. I've seen people with seroconversions following occupational exposures, but never anyone who actually developed hepatitis C with jaundice. So that's an unusual subset of patients that these guys followed, and they may not be generalizable to the rest of the world. Perhaps the reason that they are jaundiced is that they had a better immunological response to the virus, and they're killing off hepatocytes, and that's how they got jaundiced. So just keep in mind that you have to be cautious about it, but I think it's important to consider that they may not be generalizable. So some folks use the so-called preemptive therapy strategy. If the PCR is repeatedly positive, they start treating them then. We actually go for the watchful waiting strategy. We do this because of this paper by Largy and co-workers that looked at a point source epidemic of hepatitis C that occurred in a convent. All the nuns volunteered to participate in the CMV trial, and the vaccine that was being evaluated to try to prevent CMV was actually contaminated with hepatitis C. So they all got injected with hepatitis C. Only about half of them got sick. The other half of them didn't get sick, and initially they didn't understand why that was, but when someone went back and looked, all of the ones who didn't get sick and didn't make antibody had robust cellular immunity directed against hepatitis C envelope viruses or envelope antigens. And so it's likely that they naturally cleared their infection and didn't even make antibody. So we don't know how often that occurs. Most people think it's someplace between 30 and 50% of the time. So that's a real good reason to wait. to see whether after the person becomes PCR positive, if they clear the PCR positivity in a couple of months, then you don't need to do anything else with them. But if they don't, then you refer them to the hepatologist, and they'll treat them likely now with these new drugs, except they're very expensive, as I know you all know. So it's clear that there's at least one study that showed that interferon was not effective as post-exposure prophylaxis. These new drugs, serine protease inhibitors, nucleotide and nucleoside analogs, both regular drugs and non-nucleoside RNA polymerase inhibitors, are now marketed. Every class of agents, there are 15 or 20 candidates. I'm not going to go through them, but I think it's very clear that, especially looking at these combination drugs that are having astounding success in treating patients with chronic disease, the likelihood that if I win my battle against room temperature for the next 5 or 10 years and you invite me back to give a talk about hepatitis C, that we'll be using these drugs as post-exposure prophylaxis. It's just too early to call. So what about HIV? What should you do if you have an occupational exposure to HIV? Well, here's a guy who cut his arm off for a 1 in 325 risk, despite the fact that, to my knowledge, there has not yet been a placebo-controlled trial of this mode of therapy. Those of you interested in either ophthalmology or dentistry might want to look at the inset here, which also has some significance. So there is a substantial rationale in 2015 in using post-exposure prophylaxis with antiretrovirals, despite the fact that we will never have a study that shows efficacy. The reason we won't have such a study is that Burroughs Wellcome back in the day tried to do it, and no one was willing to be in the placebo arm. And it's just the fact. No one wanted to do it, so they could not recruit patients for that study. Nonetheless, there's a substantial reason to do it. We did it first, I think, in 1988, right after the person died that I told you about, or right after she got sick. I went to the medical board. We had this drug that we were studying, which was then called BW509A, which became zidovudine, and it had already been shown in several studies at the clinical center to have activity against HIV. I said, well, why don't we offer it to people and let them choose whether they want to take it or not? It gives them something to do and puts us in a position of healthcare worker advocacy, and I think that's a very important concept. There's now a substantial body of evidence that a lot of antiretrovirals block the dissemination of HIV from the dendritic cells that first hold the virus when it gets into the body. The next step in infection is it passes it off to susceptible T cells. That can be blocked by these drugs in vitro. And there are several studies that actually demonstrate this. The best of them, I think, is a study by Pope and colleagues in the Journal of Experimental Medicine. Then Clerici and co-workers showed that T cells from healthcare workers who had documented occupational exposures to HIV but didn't get infected, when you took their cells and exposed them to HIV antigens in vitro, their cells went off and made interleukin-2 in response to those antigens, when people who had not been exposed didn't do that. That same group went on to show that in an additional 20 individuals who had had occupational exposures, you could actually detect cytotoxic T lymphocytes directed against HIV envelope peptides in patients who didn't get infected. So we always just thought they didn't get exposed. I mean, they got a needle stick, but there wasn't anything there, or it just went away, basically. But what's maybe happening is that cellular immunity may be coming in and polishing this off. And that may help explain that 1 in 325 risk that we talked about earlier. So what's the available evidence in the year 2015, at least in vivo, that these drugs might work in this set of circumstances? Well, I already mentioned that the rate of transmission, it would take about 6,000 people in either arm of a placebo-controlled trial to show significance at the 5% level with a type 2 error of 0.2. And we couldn't find 30 people back in whenever it was, so that's not going to happen. But we do have a lot of indirect evidence that this works. There are elegant animal studies, there are studies of maternal fetal transmission that show efficacy, and then the CDC did a really remarkable case control study that shows evidence of drug effect as well. And finally, we have that 30 years worth of clinical experience, or 20 years of clinical experience with these drugs since 1990. Here were two of my favorite drug studies. The first of these published in AIDS in 1997 by Bottger and co-workers. They studied a drug called dideoxyhydroxymethylcytidine, and they only gave it to their macaques in this model for 3 days, and by giving it for 3 days after they had had either intravenous or intrarectal exposures to the virus, could prevent infection in 100% of cases. But my favorite study is the study was published actually in Science by Tsai and co-workers, and really an elegant model, again, SIV infection in macaques. And what they did was they took macaques and established the dose that it took to establish infection in 100% of control animals. Then they gave that dose, and then 4 hours after infection, gave 5 animals 30 milligrams per kilogram of a drug called phenoxymethylpropyladenine, PMPA, which is now marketed as tenofovir, and none of the 5 animals got infected. They also gave the same dose to 5 animals 24 hours after intravenous injection with a dose of SIV that was capable of preventing or causing infection in 100% of the control animals, and none of those 5 animals got infected. So when we started out giving cidovidine, if you had told me that there was a result like this that was even remotely possible, I would have said, I probably would have laughed and said that's not how antivirals work. But this is pretty good data in animal models, keeping in mind that animals are not humans. We also have elegant data from maternal fetal studies. Oh, let me just mention that I like the macaque model and the Tsai model because there are some other ancillary features that sort of fit my biases about the disease. First, the duration of therapy in this model is important. If you treat the animals for only 3 days, none of them are protected. If you treat them for 10 days, half of them are protected. And if you treat them for 28 days, all of them were protected. So something is happening during that period of time that's holding the virus at bay that allows something to come in and polish off the infection. I like that T-cell immunity model for that, but it's not been proved. So the maternal fetal studies I started to discuss, the most famous of these is the 076 trial that showed you could actually decrease the risk for transmission from a mom that's infected to her offspring by about 2/3 if you just gave them this regimen, which was treating the mom the last 6 weeks before her estimated date of confinement, treating her more aggressively during labor and delivery, and then treating the child after the child was born. So most people believed initially that the reason that reduction in transmission occurred was because you had lowered the mother's viral burden, and that just decreased the risk of transmitting to the child. But when Sparling and colleagues went back and looked at the data, only 30% of the reduction in transmission could be explained by lowering the maternal viral burden. And so something else was clearly going on. So then we had these 2 really terrific studies, one by Wade in the New England Journal, another by Boltries from CDC, where they looked at people who presented to the hospital and they didn't have time to give them the 076 regimen. So a mom came in precipitating in labor. She couldn't get the 6 weeks beforehand, so they could only treat her during labor and delivery. And in some instances, they didn't find out the person was infected until after the baby was born, so only the child got treated. So in the Wade study, if just the child got treated and the child got treated within 48 hours of birth, the risk for infection was 9.3% compared to their control of 26.6%. Using the 076 regimen, the risk was 6.1%, so they're almost the same. And clearly, this is post-exposure prophylaxis in humans. It's just a different route of exposure. Boltries and co-workers at CDC reproduced this study because they weren't certain of the way the cases were assembled, and what they found was that all 3 regimens worked about equally well and reduced the risk by half. So post-exposure prophylaxis for maternal fetal transmission clearly works. And finally, my friend Denise Cardo at CDC was the first author on a very important case control study that looked at the folks. CDC collected information on all the people around the country who had needle stick exposures, and then they compared the folks doing a retrospective case control study who got infected to the folks who didn't get infected to ask the question, what about the exposures for the folks that got infected? What about those exposures was different? And they found some things that I really like. As I said this morning, if we were going out to have a nice bottle of Cabernet and we're just drawing up the factors that we think might actually be incriminated. These are the ones that they found. So a deep injury is more likely to produce infection than a superficial one. If you can see the blood on the device that injures you, it's more likely to produce infection than if you can't see it. If the device had been in an artery or a vein, as opposed to used for an intramuscular injection, and if the source patient died within 60 days of the time of the event, suggesting that he or she would have had a high viral burden at that time. These are all inocula effects, so it's just inocula. All makes sense. The one thing that CDC did not anticipate was that they found that if the healthcare worker did not take zidovudine, it was a dramatically increased risk for infection. They didn't anticipate it, and they didn't believe it to start with, and so they went back and matched more patients. They got people who had gotten infected all around the world: Italy, Spain, Germany, the UK, South Africa, several places, and then matched controls out of their population with those patients, and they found exactly the same thing. So this is indirect evidence of the efficacy of post-exposure prophylaxis, but it's really pretty profound indirect evidence. Here's the best evidence. These are occupational infections that have occurred in the United States between 1985 and 2014. And I think you can see that we've done something. Something good has happened. There are a lot of factors that contribute to this, and post-exposure prophylaxis probably not at the top of the list. Highly active antiretroviral therapy is at the top of the list because it makes these patients healthier. It keeps their viral burdens down, which decreases the risk. It keeps them out of the hospital, which reduces your risk. And they also have many fewer procedures because they're healthier. So all those factors contribute, but post-exposure prophylaxis also probably contributes. Pregnancy. If a pregnant woman has an occupational exposure, we treat her exactly the same way. The occupational medicine doc has an increased responsibility to make sure that the pregnant mom understands all of her options and understands the risks that are associated with these drugs. We don't have a lot of experience giving these drugs to healthy people who are pregnant. We have a lot of experience giving them to women who are HIV infected, but it's really not the same. And there's some concern about the use of certain of these agents, and some of them definitely, such as nalfinavir and the DDI-D4T combination, that should not be used at all in pregnancy. So the current recommendations from the United States Public Health Service are raltegravir, tenofovir, plus emtricitabine, 3 drugs for everybody who has an occupational exposure. Within the year, I would anticipate that will change to dolutegravir, tenofovir, and emtricitabine, because raltegravir is twice daily and dolutegravir is once daily, so that would move us to a regimen that you would only have to take one of each of the pills in the morning, and you'll have coverage for the whole day. So that, I think, is likely going to happen sometime soon, presumably. And then the next thing you can anticipate is the drug manufacturers will get together and put all of them in a single pill, so you just have to take one, and that'll make it even better. There are lots of alternative agents. I'm not going to go through them in great detail. You need to engage your ID team and the HIV team to make sure that you have appropriate coverage if you're dealing with a resistant virus. And there are some drugs that should only be used with expert consultation, drugs like abacavir and efavirenz and other drugs listed on this list. And finally, some drugs that are really either generally not recommended or contraindicated. And the reason nevirapine is contraindicated is that 2 healthcare workers who got nevirapine as post-exposure prophylaxis rotted their livers and had to get liver transplants. So we would never use that drug any longer in this setting. So there are lots of these drugs out there. If we had made this slide up back when I first started, there would have just been one drug on it, zidovudine, but lots of available medications that attack this virus in lots of different settings. Significant guideline changes from the previous iteration is they've made them more simple. Everyone gets 3 drugs. There's no risk stratification. You saw the recommended regimens and the agents that are no longer felt to be acceptable. Some of the follow-up criteria, this would be mostly influencing your occupational medicine team, but the recommended duration of therapy hasn't changed, still 28 days, and the kinetics of administration, getting the drug on board as soon as you possibly can. There is no magical time, and every institution should probably make this one of their performance metrics. How long does it take from exposure to effective therapy being administered? Treatment has to be immediately accessible, make certain an exposure has occurred, choose a regimen that can be taken, be cognizant of the source patient's therapy and viral burden, be familiar with the agents, their side effects, and the management of toxicity, and anticipate and prophylactically treat side effects. Changed our lives with these drugs. Our compliance went from 35% to up in the 80% when we started sending people home with antiemetics and antispasmodics and things that made their lives better because the drugs made them so sick. The other really good thing is that the newer regimens are much better tolerated than the older drugs, and so you can anticipate having a very high level of adherence to the regimen. If you need help, the folks in San Francisco still run the Pep Line. Call anytime between 9 in the morning and 2 in the afternoon, East Coast time, can get them, and they can answer questions about whether you've had an exposure or what you should do about whatever has occurred. They're terrifically helpful. Does anyone know who this woman is? See? Too few gray hairs in this audience. This is Kimberly Bergalis. She was patient 1 of a Florida dentist who transmitted HIV infection to 5 of his patients. And she died from HIV infection that she acquired from her dentist. It created a firestorm in Atlanta, in Florida, where this actually happened, and in the U.S. Congress, which is just down the street from where I live. So it's important to note that patient-to-provider transmission, patient-to-patient transmission, and provider-to-patient transmission all occur, but they don't occur at the same rates. So provider-to-patient transmission started out being rare and remains incredibly rare. But our goal is to do no harm. So how do you manage the competing risk of someone who has a bloodborne virus infection with the chance that she or he might ultimately produce infection in his or her patient? It's a complicated issue, and one with which the healthcare epidemiology community and the occupational medicine community has struggled some over the last several years. So there are lots of cases of hepatitis B transmission from providers to patients. Through 1996, in a review article, CDC identified nearly 400 patients. Since 1996, there are an additional 10 reports, a lot of them for surgeons, 1 case associated with the dentist. For hepatitis C, it's been rarely reported in the United States. They've had a huge problem with it in the UK and in Europe. In the United States, all of the cases, but maybe 1, and I think probably even that 1, have been associated with the healthcare provider chipping drugs from his patient and then using the same syringe to inject whatever was in the syringe. That's not bad healthcare. That's illegal behavior. Those people go to jail. And so I think, if you made me guess, I think the same thing is going on in Europe. I just think they haven't detected it. One huge case in Spain with 1 anesthesiologist infected 269 patients. He's in jail. Happy to report. Here are our cases. Note the ones that have IVDU, which means these were healthcare workers who were drug users. And the cardiac surgeon in 2001, whose case is ascribed in the literature to being associated with his doing cardiac surgery on patients. I would point out that he is no longer alive, that he died of a heroin overdose. So I'll let you reach your own conclusion. For HIV transmission, there have been 9 cases associated with 4 providers in 25 years. 1 case in Spain, which is a gynecologist transmitted during a C-section. It's only just peripherally described, and 2 cases in France. One of them is a case that we'd agree about. It's an orthopedic surgeon who probably had an occupational infection, didn't know it, was very sick and just kept operating and never went to see the doctor, had a very high viral burden and was doing a redo hip, which lasted like 12 or 14 hours. It's a case where you would very likely have an occupational exposure. He had a very high viral burden. That case is no mystery to me. That's what the bumper sticker says, stuff happens. But the other case in France is a nurse who had both HIV and HCV infection, and she only provided postoperative care for a patient who had had an abdominal surgery. Now, the fact that she had HCV infection and HIV infection might make you wonder, but the paper says that she had no evidence of drug abuse. I don't believe it for a second. So, as Selwyn mentioned, we wrote these guidelines. The Public Health Service guidelines still say you can't do these procedures, but we have made a recommendation that under circumstances, people be allowed to operate or do exposure-prone procedures. If for hepatitis B and C, if your viral burden is less than 10 to the fourth genome equivalents per milliliter, you have to do some other things, which I'll tell you about in just a second, but we would allow you to go ahead and do exposure-prone procedures. The same with C, as I mentioned. And for HIV, we were the first group ever to make a recommendation that someone who's HIV infected and has his or her viral burden suppressed below 500. The reason we use 500 is people who are completely suppressed have little blips sometimes, and so 500 catches all those people. We would allow them to do it as well because we think the risk is infinitesimally small. I don't think it's zero, but there aren't zero risks available in a lot of other venues in the healthcare setting, and I think this makes the most sense. The codicils, the person cannot be detected as having transmitted infection, has to obtain advice about his practice or her practice from an expert review panel, undergoes routine follow-up by occupational medicine or public health officials, receives follow-up by his or her personal physician who has expertise in the management of the infection we're talking about, consults with an expert in hospital epidemiology about the optimal infection control procedures to be followed, and agrees to the information in and signs a contract that she or he will follow all these guidelines. So who's this guy? Yep, it is. It certainly is. He's the guy who said when you come to a fork in the road, take it. And I admire that because it sort of describes my life. But he also said, come on, you got to be very careful if you don't know where you're going because you might not get there. And I think for this issue, especially the infected provider issue, you really have to be cautious. It's analogous to playing golf on a golf course that has a very narrow fairway. It's really easy to get into the woods on either side of the fairway on this issue. And you have to think about it constantly, focusing on the magnitude of risk. So what about that risk? If you look, some of these may be striking figures for some of you. Your lifetime risk of dying from heart disease in the United States is about 1 in 5, cancer about 1 in 7, stroke about 1 in 24, dying from a hospital infection about 1 in 38. These are real numbers. Wow. Your chance of dying from iatrogenic HIV infection is about 1 in 18 million. So if you're going to worry about that, you have to worry about a few other things on the list as well. Every decision you make in life is associated with risk. We don't often think of it. The fish has 3 bad choices. My brother often complains to me that I give him choices when we have conversations, but they're often all bad. Sometimes that's all that are out there. But you have to keep in mind that every little decision you make, whether you get on the freeway or stay on the side roads, whether you take the airplane or the train, all these are risk calculi that you make in your own mind. And we do it every day as part of our lives. If you keep these risks ordered, then I think it's easier for all of us to create the safer environment that we need in our hospital for us and for our patients and provide the highest quality of care for these patients. Thank you very much for your time and attention. Yep. I'm happy to take questions if anyone has questions. I'm not sure I have answers, but I'm happy to do it.
Insights into his expertise. For those of you that don't know who I am, I'm Alva Cass. I'm the medical director for Employee Health Services. And all I can say is that we really do want to make UTMB one of the safest places in the country to work. We need your help. If there is an incident, regardless of how major or how minor, report it to us. We have our nursing staff that is well versed in this. They will answer your questions. We have 3 doctors in the Employee Health Service that deal with it on a day-to-day basis. We'll do everything we can to answer your questions. When we can't answer them, we have Dr. Mayhall to go to. And when he can't answer them, he has the ID team to go to. So we have just marvelous expertise here at UTMB to help out with any of these things. And we really want to do the best we can. We are having a higher rate of exposures than we want to have. In the last year, we were nearly 5 times the rate reported in EpiNet, 4 to 5 times the rate in EpiNet. We've got to do something to change that. And I think it is one of awareness one of caution, one of taking advantage of all safety devices that we can, and one of reporting this so that we can understand where some of these root causes are and make a difference. So you help us and we'll help you. Thank you.
Terrific. Thank you. Other questions?
Well, Dr. Henderson, I want to thank you for an excellent talk and a historical overview of a epidemic that's now actually a chronic disease.
Yeah.
I mean, I think of how fascinating it is when Magic Johnson came out and said that he was HIV positive, and 2 years later he was back on the NBA court for a short period of time. Where is the future of HIV cure in particular, given the fact that we're now entering a chronic disease? It's probably better to have HIV than to have end-stage heart
Absolutely.
disease.
I mean, given the choice today, I would choose HIV infection over congestive heart failure, because my lifespan would be much longer, even at my advanced age, for certain, because we're doing so well with it. The biggest problem, as I know you know, is in Africa. We're doing better. I think the NIH has had a hand in that. Tony Fauci, the PEPFAR initiative has made a big difference. There's a lot of work to do. It's a terrible disease, and we're gaining on it. The future of HIV care, if we maintain these new drugs, and they turn out to have as few side effects as they appear to have, and they maintain their efficacy, and we follow behind them with additional drugs when resistance develops, I think would be probably worse to have type 2 diabetes. I mean, we're at that point now in the management of these patients. Now, the downside of that is the drugs are expensive. They cost a lot of money. And so someone's going to have to pay for those, and the likelihood is going to be you and me. So stay tuned, but it's a challenge.
UTMB Health, working together to work wonders.